All right, students, this is Joyce Chenard. Today I'm going to go over how to read telemetry strips, which has historically been quite a challenge for new graduates and student nurses to learn how to do. It can be very intimidating, so we are going to take our time and work through a bunch of practice strips together, talk about what the heart's doing, and talk about how that presents on our telemetry read. First and foremost, I want you to understand that telemetry is a reading of the electrical activity of the heart. It's not telling me anything else. It's not telling me blood pressure. It doesn't tell me how much blood is in the heart. It doesn't tell me that the heart is red. All it's telling me is the electrical activity of the heart. And then with that information, we can then interpret how the heart is likely behaving. So if you haven't already, I can email you the two documents that I'm going to use with this tutorial. So the first thing is learning how to read telestrips, which talks about what we just said, that it is a continuous reading of the electrical activity of the heart. And in order to do that, we have to place electrodes on our patient. Most places use a 5-lead telemonitor. Some places just use a 3. If your place or wherever you're at for clinical just uses a 3-lead tracing, start with your white to right. Put your white electrode on the right shoulder of the patient, and then smoke over fire, meaning the black lead, which is your smoke, goes over the red lead, which is your fire. If you're at a facility that uses a 5-lead tracing, you would have a brown and a green lead. So you would put your brown over your heart, because I love chocolate. That's how I remember that. And then green would be snow over grass. So if you can remember white to right, smoke over fire, the other two will be a lot easier to do. And then how do you start to understand what is a telemetry read or interpretation? Read it like a sentence. Students, read it in a systematic way every single time. And after reading the data, then you interpret it and give a rhythm analysis. Your main 3 sections are your P wave, which is your atrial contraction, your QRS complex, which is your ventricle contraction, and your T wave, which is repolarization. Let's come over here to our blackboard and we're going to go over that a little bit further before we start doing our practice strips. So we have our SA node. You can remember from A and P, we've got our SA node. When that fires, it will make the atria contract. Then you have your AV node, and when that fires, then your ventricles contract. So as you remember from A and P, your atria contract together and your ventricles contract together. So your atria, then your ventricles, your atria, then your ventricles. Coming back over here, students, I want you to know that after your AV node, you have what is called bundle branches. You have one bundle branch to the left side. You have two bundle branches to the right, or one bundle branch to the right side and two bundle branches to the left side. And that should make sense because your left ventricle has to be bigger. Your left ventricle is what is pumping blood to the rest of your body. So you have one bundle branch to the right side because that's just pumping blood over to your heart. And then you've got this big left ventricle that has two bundle branches, and that is pumping blood to the rest of your body. Coming over here, I have these color coded to help you. So your P wave on your telemetry strip, your P wave is your atria contracting. So that is your SA node making your atria contracting. So that's this, that's your P wave. Then you have your QRS, that is your ventricles contracting. So your QRS, the taller skinny one, that is your ventricles contracting. And then you have your T wave, which is what we call repolarization. Students, that basically is all of the ions like your sodium and potassium going back to where the starting point, going back to where they were. Think of your T wave, think of repolarization as the recharge. That's your ions going back to where they were so that it's ready for another heartbeat. So we've got our atria, our ventricles, and our repolarization. When we read our telemetry strips, and this will make more in just a second, we read it from left to right. It's in seconds or time. One little box is 0.04 seconds, one big box is 0.2. And the best way to start learning how to interpret strips is to start practicing with them. So let me switch over here and clear this out. There we go. And we are going to start reading some strips together. Okay, get my pen here. All right, so a lot of times when you are quizzed or you interpret a strip, most often it's printed out as a 6-second strip. And so if you think about it, if you have 6 seconds, whatever the rate is, if I times that by 10, that's going to be for 60 seconds. And here is why that is easy to know. So if I count on this 6-second strip, if I count how many heartbeats there are, 1, 2, 3, 4, 5, 6, 7. So if I take 7 times 10, then I have how many heart rate or heartbeats there are in 60 seconds. So this patient's heart rate is going to be 70. Okay, so if I times that by 10, that's what my pulse would be for a whole minute. All right, so when I was saying that we are going to collect our data and then give our rhythm analysis, this is how we do that. We always start with our rate first, so our rate is 70. And then we're going to determine if it's regular. And so how I do that is I measure from the top of the R wave to the top of the R wave on the next one. You can either use a caliper or you can use a just a scratch piece of paper. Put a piece of paper up here, make 2 little tick marks on your scratch piece of paper, and then march it out to see if it's regular. And this one is. The next thing we're going to do is we are going to measure our PR interval. And so our PR interval, this is the beginning of our P wave. This is the end of our P wave. So if we come back over here to our blackboard, this is the beginning of our P wave. So I'm going to measure from here to when it leaves baseline again for our QRS. Put this back on here. There we go. So we are going to measure from this little line. So we'll start here and we'll start counting. 1, 2, 3, 4. Okay. We'll start here. We'll double check it. 1, 2, 3, 4. So we've got 4 little boxes. And if you remember, they are 0.04 seconds each. So that would be our PR interval would be 0.16. So let's look at our QRS now. We're going to measure, oops, we're going to measure the second portion, the QRS interval, which is this right here. So let's start here. We'll measure from here and then we'll go 1, 2. It's about 2 boxes. So if it starts here, we got 1, 2. Okay. So that would be 0.08. The next thing we need to know is there one P wave for every QRS? So looking back at our blackboard, is there one P wave for every one QRS? And let's see, it looks like we've got a P wave here, and then we've got a QRS. We've got a P wave here, and then a QRS. Yep, I'd say that's a 1-to-1. So yes. And then we've got our QT interval. So looking over here at our blackboard again, our QT interval, we're going to measure from here, from the beginning when it goes off of baseline, our Q wave, to the end of our T wave. This might help you guys. So we're going to measure our QT interval from here to the end of our T wave. When we're measuring, the normal PR interval is 3 to 5 boxes. The normal QRS is 1 to 3. And then our QT is supposed to be, well, the goal is less than 11 boxes. Let's come back over here. So let's measure our QT interval. And we've got, start here, we'll go 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, that's about 9 boxes. So 9 times 0.04 is 0.36. So we've got a rate of 70, it's regular, our PR interval, so our electrical activity for our atria is normal. Our QRS is 0.08, and it looks like the electrical activity for our QRS is normal. We've got one P wave for every QRS, meaning every time the atria contracts, the ventricles contract, and our QT interval is not prolonged, so it's not greater than 11 boxes. So our rhythm analysis here is normal sinus rhythm. Okay, so we've interpreted our first strip. All right, so let's go ahead and erase that and we will go to our next strip. Okay, so the first thing we're going to do is, this is a 6-second strip, so we're going to use our shorthand method to calculate out what the heart rate is. So we've got 4 times 10, so our heart rate is 40. Is it regular? If I was to take my calipers and measure those out, those are regular. So that would be yes. Our PR interval here is our P wave. And so if we measure out how many little boxes our P wave is, that's 4 little boxes. So it would be 0.16, because remember 4 times 0.04. Okay, and then we've got our QRS. So let's go ahead and, I know some of these aren't super clear, but this looks like it to be about 2 boxes wide. So we've got 2 boxes times 0.04, and that makes 0.08. Is there one P wave to one QRS? There's our P wave, here's our QRS, there's our P wave, there's our QRS. So, yep. And then our QT interval, let's look and see how many boxes that is. So we've got this starting here. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 2, 3. Yeah, I'd say that would be about 12. So 12 times 0.04 would be, so we've got sinus, because we have a P wave for every QRS. You guys know already that bradycardia means our heart rate is lower than 60. So we've got sinus bradycardia with a prolonged QT, because this is greater than 11 boxes, or greater than 0.44. Stay with me, students. This starts making a lot more sense the more you do it. All right, so we're going to go to our third strip. First thing we're going to do is we're going to use our shorthand for calculating out what the rate is. So we've got 1, 2, 3. Ooh, they're clicking along at 140. Is this regular? If I was to mark my R waves out, they would march out. So we're going to put yes. Our PR interval, well, this is kind of hard to read because our patient's heart rate is going so fast that the P wave, ooh, excuse me, the P wave is starting to get lost in the T wave, but we're going to do our best. So this looks to be about, so I start here, 1, 2, 3, 4. Start here, 1, 2, 3, 4. So about 0.16. Our QRS interval looks to be about 2 boxes. Oops. Do we have one P wave to one QRS? There's our P wave, there's our QRS. P wave, QRS, P wave, QRS, P wave, QRS. Yes, and then let's look at our QT interval. So we'll start here. 3, 4, 5. Yep, that looks about 7 boxes. Okay, so we've got 7 boxes times 0.04, 0.28. So with this information, this is sinus, okay, because we have a P wave for every QRS. Our heart rate is high, so we have tachycardia. So we have sinus tachycardia, okay, and our QT interval is normal. So we've got sinus tachycardia. Coming down here to our next one, let's go ahead and use our shorthand for, I'll make this a little bit, okay, got 1, 2, 3, 4, 5, 6, 7, 8. All right, so we got a heart rate of 80. We'll put that here. Is this regular? Well, if I was to measure out my R wave from here to here, that is a lot wider than my R wave from here to here and here to here. But then it's wide again and then shorter. and then wide. So is it regular? No. Let's look at our PR interval. So measuring our P wave again. If we measure this out, that's about 4 boxes there. Yep, 4 boxes. Okay, so we've got a PR interval of 0.16. Our QRS interval looks a little skinnier. It looks to be about 1.5 boxes. And that's okay, students. You can have half, measure it out as 1.5 boxes. Is there one P wave to every one QRS? So we've got a P wave, a QRS, a P wave, a QRS, a P wave, a QRS. So yes. And then looking at our QT interval, it's 1, 2, 3, 4, 5, 6, 7, 8. All right, that's about 8. So, all right, so I've got a normal heart rate of 80, but we're not regular. Our PR interval time-wise looks good. Our QRS interval looks really good. We've got a P wave for every QRS, and our QT isn't prolonged. So what this means is we have sinus arrhythmia. Boy, I can't spell. So it's sinus because I've got a P wave with every QRS, but it's not in rhythm. So it's sinus arrhythmia because it's irregular. Let's come on here down to our next strip. There we go. Okay. So starting off, we've got 1, 2, 3, 4, 5, 6. So our heart rate is 60. Let's go ahead and write that here. Is this regular? If I measure out my R waves, they're pretty regular in this case. I'll put yes. My PR interval. Uh-oh. So now we're in trouble because this is likely my T wave, but then I've got 1, 2, 3 P waves. Well, I can't very well calculate out the PR interval if I've got 3 P waves. So students, this is one of the reasons why we do rhythm interpretations. So knowing what your P wave is, you know that is the ventricle, or you know that is the atria completely contracting, is when your P wave, that's your atria completely contracting. When you have this type of rhythm strip going on, your atria is not completely contracting. What it's doing is it's fluttering. So it's kind of doing like a half contraction. Okay. Not completely getting all the blood out of the atria. It's just kind of partial, not a complete contraction. Let's come back over here to here. So when the heart is firing correctly and the SA node fires the way it's supposed to, it fires, the atria make a complete contraction, and we go on with life. But when you have what's going on there on our rhythm strip, you have like an irritable point. Like there's like one irritable point that keeps firing just before the SA node does, and it kind of takes over. And it doesn't do a super good job, and so the atria only makes a partial contraction, and you get what we call a sawtooth rhythm. So if you guys know what a sawtooth looks like on a saw, that is what we are seeing here. This is a sawtooth rhythm. That means that the atria are not making a complete contraction. It's just like a partial one from one irritable point. So let's go ahead and interpret that strip and see what that means. So we don't have a PR interval. Our QRS, let's see, that looks to be about 2 boxes. Is there one P wave to one QRS? No. And then what's our Q2? 1, 2, 3, 4, 5, 6, 7. Start here. 1, 2, 3, 4, 5, 6, 7. It looks to be about 7 boxes. So we'll put 0.36. Whoops. 0.28. Okay. So this is called a flutter, meaning atrial flutter. The atria are just fluttering instead of making a complete contraction. Stay with me. This will make a little bit more sense here in just a minute. Coming down here to our second strip on the screen. So we've got 1, 2, 3, 4, 5, 6, 7, 8. Okay, so we've got a heart rate of 80. Is this regular? Absolutely not. There's a lot more space between here than here, so no. PR interval. Uh-oh, we have no P waves, so we can't measure that because we have no P waves. Our QRS, that looks mostly normal. Let's say 1, 2, 3. I'd say that's probably about three boxes or so. So we'll put 0.12. Do we have a P wave for every one QRS? Nope. And then our QT interval, well, it's kind of hard to say because I don't know exactly where my T waves are. So with this, I mean, obviously there's some sort of electric activity, but it's not enough. Whoops. So what the atria are doing with this patient is it's just fibrillating. So when you have heart muscle that is just fibrillating, that means there's little sparkles going off, but not enough of really any consequence. So it's just fibrillating here, and it's not pumping anything. So the atria aren't pumping anything, and it's got just a little bit of sparkles for electrical activity. And every so often, one impulse actually gets through, fires the AV node, and it makes the ventricles contract the way they're supposed to. So if we come over here, so we got our SA node, that isn't working at all. That's why we don't have a P wave. And so with atrial fibrillation, which is what's going on with our patient, you get a little sparkle over here and here and here and here and here and back over here, and it's just all over the place. And then every once in a while, it actually gets through the AV node and it makes the ventricle contract. That is why patients in AFib historically have got irregular heart rhythms, because the impulses from the atria do not consistently get through to the ventricles. So sometimes you can have somebody with atrial fib with a normal heart rate. Sometimes it's high, sometimes it's low. We have to watch those patients a little bit closer because their electrical activity is not consistent. Okay. This is also why, because it's just um, fibrillating up there at the top and it's not actually contracting, blood will actually pool in the atria, and that is why we put those patients on blood thinners, because in case they were to be in AFib and then suddenly go into sinus and have their atria completely contract, they can kick out a clot and have a stroke or a PE or wherever it lands. Um, so we got fibrillation, we've got flutter, so it's like a somewhat more consistent atrial contraction, but not a complete one. And then you have your actual P wave where the atria completely contracts. Okay. So if we come back over here, so the interpretation for this, students, would be atrial fibrillation, also known as AFib. Up here, a lot of times we call this A flutter or just flutter, but it's technically it's atrial flutter. Okay. Your patients with AFib, let's come back over here. Your patients with AFib, let me come down here to this one. Your atria, oh, let me make that a lighter color so you guys can see that. I'd like to make this point right now, students, that I am not a digital creator. I happen to be a nurse in my basement trying to make tutorials to make your life better. Okay? All right. So, your atria, they do about 15% of the work. Okay? So when your patients are in AFib, some patients can feel when they go into AFib, and like they feel more tired, they feel more short of breath. Like they'll come in and be like, I've gone back into AFib. Not every patient knows when they flip into AFib. Some people flip in and out of it and they have no clue. Um, but some patients, they can tell you when they flip into AFib because they can feel that difference. call this your atrial kick. So patients who are in AFib, they have lost about 15% of kind of like their heart's workload. So they're a little more tired, not quite have as much energy. Okay, let's come back over here. I'm going to scroll down to our next rhythm. We'll get that taken off of there. Switch back over to purple. There we go. Okay, so let's start with this rhythm analysis. We've got 1, 2, 3. Whew. All right, so on our 6-second strip, so 20 times 10, our heart rate is at 200 for this patient. Is it regular? Well, if I'm to measure out my R waves, that looks pretty regular. PR interval. Oh, see, now we've got a problem because I can't tell if that's a P wave or a T wave. Okay? Because this heart rate is going so fast, I can't tell if it's a P wave or a T wave. So I'm not able to measure that. QRS, that's about a box and a half. Yeah. So we'll say 0.6. Is there one P wave to one QRS? That's anybody's guess because I can't see the P wave. Our QT interval, I can't really measure that because I don't know if that's the P wave or the T wave. So how would I interpret this? Obviously, we've got some sort of tachycardia because our heart rate is 200. Um, this is considered SVT. Let me write that out for you. Supraventricular tachycardia. This means that my ventricles are beating correctly because my QRS is normal. So I know that impulse that's going through the AV node is coming from above the AV node. So let's go back over to our blackboard so that can make a little bit more sense. Supraventricular tachycardia. That means it's probably firing from the SA node, and it's this is misbehaving up here, but every impulse that goes down from up here is making it through the AV node and getting my ventricles to contract. And at least my ventricles are contracting the way they're supposed to be because my QRS complex is skinny. It's the 1 to 3 boxes like it's supposed to be. Because if you guys remember back here from this blackboard slide over here, our normal is 1 to 3 boxes for our QRS, and this is, so that's a good thing. So we have supraventricular tachycardia. There's different types of tachycardia, but if that impulse starts from above the AV node, it's a supraventricular tachycardia. Let's come down here to our next one. Okay. All right, let's go ahead and mark this one up here. So we've got 1, 2, oops. All right, so our heart rate is 80. Oh, you can't see that. Okay. So 80. Is it regular? Well, that looks a whole lot skinnier than that, so no. Okay. And then we've got our PR interval. So we have a PR interval here, and this little P wave, he looks a little bit different, but then this one looks the same, this one looks the same, same, different. So let's go ahead and measure our PR interval from the ones that are looking the same. And so I would say those are probably about 5 boxes. Yeah, we'll say zero point 0.2. Our QRS interval looks about 2 boxes, so we'll say 0.08. Is there one P wave to every one QRS? Yes, we have one P wave, one QRS. One P wave, one QRS. One P wave, one QRS. They look a little bit different, but yes, we do have one P wave to every one QRS. And then our QT interval, let's see, I'd say about 10 boxes. Maybe about 9 there. Yeah, we'll say 10. Okay, so our rhythm analysis, we do have a regular rate. It's not regular. We have a good rate though. We have a PR interval, we have a QRS. These two are within normal limits. We've got a P wave, and our QT is not prolonged. This is sinus rhythm with PACs. And students, what PACs are premature atrial contractions. So premature atrial contractions. Let's come over to our blackboard. This is what's happening. So we've got our SA node, but every once in a while there's a little irritable part over here or maybe over here that is causing it pretty close to the SA node that is causing the atria to contract and fire before it's supposed to. So our SA node, remember from A&P, that's our pacemaker. And for the most part on that patient, it's firing and um, going through the process like it's supposed to. But once in a while, there's a little premature area that's irritable, and it'll have a premature atrial contraction. And that is how it looks on this strip right here. You got one right here and one right here. All right, coming down here to our next strip. Get rid of that. Okay, so we've got, make this a little bit bigger. There we go. One, two. All right, so we got a heart rate of 70. Is this regular if I mark off my R waves? Yep, that looks pretty regular. My PR interval, oh my goodness, look how big my PR interval is. All right, so if we count that out, students, my PR interval looks to be about 8 boxes. It's not our 3 to 5 boxes, it's 8 boxes, so it's definitely elongated. And then my QRS, it's about 2 boxes. Do we have one P wave to every one QRS? P wave, QRS, P wave, QRS, P wave, QRS. Yes, and then my QT interval, 1, 2, 3, 4, 5, 6, 7, 8. Oh, looks about 9, so we'll say 0.36. All right, so our rhythm analysis is sinus rhythm with a first degree heart block. All right, so coming back over here to our blackboard, all of your heart block students, what your heart blocks mean is that you've got your SA node firing and then it's running into a little bit of problem here at the AV node. Just to confuse all nursing students, there are 4 different types of heart blocks, and there are 4 different types of heart blocks. We've got first degree heart block, and then we've got second degree heart block type 1, and then second degree heart block type 2, and then a third degree heart block. So coming over here to our blackboard, a first degree heart block, let me put this back into white. A first degree heart block means the block is just right up here. So that means when the SA node fires, it takes that impulse just a little bit longer to get through the AV node. There are a lot of people who have a first degree heart block, and that's just normal for them. So the conduction from the top part of the heart gets through to the bottom part on a regular basis. It just takes just a little bit longer for that to happen. Okay. And then you've got your second degree heart block type 1, your second degree heart block type 2. Third degree heart block students means that there is no discussion, no impulse between the top part of the heart and the bottom part of the heart. A third degree heart block is a complete heart block. So the top part of the heart and the bottom part of the heart are no longer in sync. There is no electrical activity from the top part of the heart that gets to the bottom. Those people need a pacemaker because their electrical conduction is completely cut off between the atria and the ventricles. All right, so getting back over here, switch this back over to purple. Okay. All right, so we did this. This was normal sinus rhythm with a first degree heart block. Let's come down here to this one. Okay. Let's calculate out our heart rate. Whoops. All right, so we know we're Brady because our heart rate's only in the 50s. Is it regular? Well, the distance between that and the distance between this looks pretty irregular to me, so no. Our PR interval. So here's the PR interval for this one. Here's the PR interval here, and this isn't the same as this. And then we have another P wave, but it's missing the QRS. So here we go back here and we've got a PR interval that's short, then it's a little bit longer, and it's a little bit longer, and then it's completely dropped. So what in the heck is going on here? We'll come back to that in just a second. Let's look at your QRS interval. Our QRS interval, that's about 2 boxes. Is there one P wave to every one QRS? No, because we've got a P wave here and we don't have a QRS. We've got a P wave here and we don't have a QRS. And let's go ahead and look at our QT interval. 3, 4, 5, 6, 7. It's about 9, so 0.36. That looks pretty normal. All right, so our rhythm analysis. This is another type of heart block, students. So we have got a type 2, also known as Winky Bach. Pretty sure that's how you spell that. All right, so this type of heart block is a little bit more severe than what our first degree heart block is. How I remember it in my head, which is not always the most, whatever. So you've got your first degree heart block, which we just talked about. Your second degree heart block, type 1, is called Winky Bach. The PR interval gets longer and longer, and then all of a sudden it doesn't go through. So your SA node is firing and it's sending the impulse down to the AV node. And each time it does that, it takes it a little bit longer to go through, and then there's finally one that drops and doesn't go through. So how I remember it is when you date somebody, usually you wink first, so that's Winky Bach, and then your dates get a little bit longer and a little bit longer and a little bit longer, and then you drop your date. That's how I remember it. So you wink first, so that's the second degree heart block, first type. Winky Bach. Your PR interval gets longer and longer and longer, and then you drop it. So you'll remember it. All right, let's go to our next one here. Scoot this down just a little bit further. Oops, too far. Okay. Alrighty, so we have got, oops, I gotta switch this. Okay. So 1, 2, 3, 4. Heart rate's in the 40s, so we're definitely Brady. Are we regular? Actually, yes. Is there a PR interval? Yeah, but here's a P wave, here's a P wave, here's a P wave. Here's a P wave, here's a P wave, here's a P wave. So we've got, this is what we call an irregular regular heart rate. Can't really calculate that PR interval. Our QRS, that's about 2 boxes. Is there one P wave to one QRS? No, because we've got these 3 P waves and then a QRS. Our QT interval, let's calculate that out. 1, 2, 3, 4. It's about 8. Okay, that looks good. All right, so our rhythm analysis, this is a 2nd degree heart block, type 2, also known as Mobitz type. So we've got 2nd degree type 2. This is our, you don't see this rhythm very often. It's your irregular regular. So your P wave, you've got your atria contracting, and the proportion will be different for each patient. Sometimes it's every 2 P waves and then you get a ventricle contraction. Or sometimes with this patient, you've got 3 P waves and then finally one gets through. Or sometimes you'll have 4 and one gets through. And so this type of heart block is more severe than type 1 and the Winky Bach. So you have to watch these patients because sometimes they can progress into a complete heart block. Okay, so we've got that, and it's very rhythmic. It's like motorized. Think that's your Mobitz. That's your motorized one. You've got this going along, but it eventually works. Okay, let's come back over here. Take that off. Scroll this down just a little bit further. There we go. Okay. All right, so we have got 1, 2, 3. Okay, so our patient's not looking so great because their heart rate's in the 30s. Going from the R waves, that is pretty regular. Our PR interval, well, we got a P wave here, here. I think that's a little bit of one there. There's kind of a P wave over here. So sometimes we've got 3 P waves and then a QRS. Sometimes we've got 2 and then a QRS. There's no way we can measure that PR interval. Our QRS interval also looks really sick as well. Our QRS interval is very wide, and I think I counted that out to be 8 boxes. Yeah, so 0.32. Is there one P wave to one QRS? Nope. And then QT, gosh, I don't even know how you would measure that because it's all over. Okay, so this, students, if you were to take your caliper or your piece of paper and you were to measure your P waves are very regular. Okay, if you were to take your calipers and measure your QRS, that too would be very regular. However, none of the P waves are syncing up to the QRS waves. This is a complete heart block. Or 3rd degree heart block. So that is like what I was just talking about earlier. You've got the atria that's contracting along and the ventricles that are contracting, but there's absolutely no conduction getting through from the atria down to the ventricles. Okay, this patient needs a pacemaker. I threw this strip in here too. I just wanted to kind of point something out here. Let me take that off. All right, so we have a heart rate that's very low, right? It's only 30. Our QRS looks pretty good though. Okay, our QRS looks, I don't know, like 2 boxes, 0.08. The QT, that looks okay at, I don't know, that is kind of long though. We got a prolonged QT. This is why I threw this strip in here. Anytime you regularly see an upside down P wave, this is considered a junctional rhythm. They are usually very Brady, meaning their heart rate is really low. This is called a junctional rhythm. Let's go back over here to our blackboard and that'll make a little bit more sense. A junctional, this is considered your AV junction, okay? When you have a junctional rhythm, let me get my white thing here. Whoops. Take that off of there. Okay. When you have a junctional rhythm, that means your AV node is firing like your SA node is supposed to, and you'll have your QRS complex, but then you'll also have an upside down P wave because it's actually sending an electrical impulse up the incorrect way. So the atria really is, it's not contracting like it's supposed to, but an AV node that's firing and it's sending an electrical impulse up backwards, that will cause an upside down P wave on your tele strip. Okay. All right. Let's go here to the next one. Let me take off that white mark. Switch it back over to purple. There we are. Okay, we got 1, 2. We're not going to count that. 3, 4, 5. All right, so we got a heart rate of 50. Is it regular? Well, looking at this R wave to this R wave to this R wave, no. And then looking at our P wave to our QRS wave. Oops. Let's say about 2 boxes. Or no, here's our PR interval. It's about 4, so 1, 1, 6. Is there one P wave to one QRS? So we've got one P wave to one QRS. We're not going to count that for right now. One P wave to one QRS, one P wave to one QRS. Yes. And then our QT interval, let's find a healthy looking heartbeat. That's about 9. Okay. So this would be sinus Brady with, so we've got sinus because we've got a P wave and a QRS. We're Brady because the heart rate is in the 50s with premature ventricular contractions. So premature ventricular contractions. So what that means, let's go back over to our blackboard. So instead of the AV node firing and causing every single ventricular contraction, there is an irritable spot in there somewhere that is firing prematurely before the AV node contracts or fires. And so it's so you've got your patient's heartbeat, so the ventricles are contracting the way they're supposed to, but then there's like a premature one, and then it goes back to normal, and then a premature one. So there is something irritable in that portion of the heart that is causing it to beat prematurely. So students, you can have 2 different types of PVCs or premature ventricular contractions. They can either be monofocal, so meaning the same irritable part of the ventricle is firing each time, or it can be from multiple different areas. So this looks the same as this, looks the same as this. So that is telling me it's likely firing from the same irritable spot and the PVCs are consistent. It looks like they're monofocal. Monofocal. So I want you to write that down. These are monofocal PVCs. Okay. All right, we're going to go to our next one here. Oops. All right, we've got 1, 2, 3, 4, 5. Oops, I need to make that smaller. There we go. So our heart rate again is in the 50s. Regular, nope, you can tell that that's not a regular. This R wave to this R wave to this R wave, they are not regular. PR interval, if I look at my PRs, be about 12. QRS is about 0.06. It's about a box and a half. Those are pretty skinny. Is there one P wave to every one QRS? P wave QRS, P wave QRS, P wave QRS. Yes. And my QT, it's about 3.2. About 32. It's about 8 boxes. Yep. Okay. So my rhythm analysis is going to be sinus Brady with multifocal PVCs. This PVC here looks like it came from the same focal irritable point here. Okay, these two look the same. This one looks different. So this one is from a different irritable part in the ventricle. So we've got our normal QRS here, 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 and here, but we've got a PVC here and a PVC here that looks like they came from the same irritable part. And then this one looks like it's a little bit different. So this heart muscle is a lot more irritable than what the one before we just did. These are monofocal PVCs. These are multifocal PVCs. So watch this patient because their heart is more irritable. Also, too, so like if your patient has electrolyte disturbances, they're going to be more likely to have PVCs because their electrolytes are off. Another thing, if you've been in my clinical group, you know that I sometimes say a big heart in cardiology, a big heart is a bad thing. If your patient has CHF and they have an enlarged heart, think of it as the wires getting stretched out. Okay? If your patient's wires, electrical activity in their heart is stretched out, they're more likely to have PACs and PVCs. So patients in CHF with an enlarged heart, they're more likely to have irregular beats because their wiring is stretched out. Okay? Think of it that way. All right. All right, so we've got our next one. Let's do 1, 2. All right, so we got a heart rate of 70. Is it regular? For the most part, yes. We're going to say yes. Our PR interval looks about 0.16. And students too, when you're interpreting your strips, I'm kind of going through here like you might count something as 12, I might count something as 16, the next nurse might count something as like 0.14. And that's fine because the general overall interpretation should be about the same. So, I might count a QRS interval as 0.08. If you count it as 0.06, it's really not going to make that much difference on the overall interpretation. Even if it's just a little bit off, it's fine. Okay. We've got our QRS. Those are pretty skinny QRS. So we're going to say those are a box and a half at 0.06. Do we have one P wave for every one QRS? Yes. Our QT interval, that looks pretty good. I'm sure these are kind of hard for you guys to read on your screen. I apologize. I used to always teach this in person. Um, but since our program has grown, I don't always have a chance to teach all of you guys at one time. When I taught at Wesleyan, I had all of this. I had all of the med-surg clinicals, so that was a little bit easier to do that. All right, so we have normal sinus rhythm. So we've got normal sinus rhythm with looks like some monofocal PVCs. And when you have two PVCs, this is why I put this in here. When you have two PVCs together, it's called a couplet. So we got normal sinus rhythm with some couplets here and here. All right, let's go down here to our next one. And take off that. All right, so we've got, all right, we got our rate. So we're gonna 1, 2, 3. And if you notice, students, I'm not counting the PVCs. Okay. So we've got a rate of 30. However, your telemonitor up at the nurse's station, it might count this. So it's really, again, it's really good to understand what's going on with your tele strips and looking at your patient, looking at their rhythm, because the telemetry monitor might say that the heart rate is 60 because it could be counting these as well. Okay. And sometimes too, if you've ever been in my clinical group, sometimes you'll see me listen apically to the patient, and I'll put my fingers on their radial pulse because I want to hear if every apical beat is perfusing all the way down. Sometimes PVCs are not effective, and so they don't perfuse, but sometimes the irritable point on the bundles, it's enough to make the ventricles actually beat and perfuse. So with this patient, I would listen apically, and I would feel their pulse to see if every single one is perfusing. Or if you're working in the ICU, if they've got the pulse ox on, their pulse ox might only read a heart rate of 30, but apically the tele monitor is saying they have a heart rate of 60. This is how that happens, is what you're seeing right here on this rhythm strip. Sometimes PVCs perfuse, sometimes they don't. Okay. All right, so we're going to come back over here and see if it's regular. We're going to say yes for now because this to this to this is pretty regular. Our PR interval, let's see here. Let's see how many little boxes we got. Oops. Say that's about 3, 4. We'll go in the middle. Our QRS interval, those are pretty skinny too, about a box and a half. Is there one P wave for every one QRS? That looks pretty good. And then our QT interval, I think that might be right at 11. Yeah, we'll say 11, so 0.44. So that's okay. Okay, so our rhythm analysis, when you have a PVC and then a normal beat and then a PVC and then a normal beat and then a PVC, this is called bigeminy. Bi means two. Okay, that means every other heartbeat is a PVC. Coming down here to the next one, I think you guys are really starting to catch on here. So we've got, whoops, let me clear that. So we've got 1, 2, 3, 4, 5. Our heart rate is 50. Is it regular? No. Our PR interval is 0.16. Our QRS for the normal ones, those look pretty good. Is there one P wave to one QRS? Yes. And our QT, it's about 8 boxes. When you have a regular beat, 2 regular beats, and then the third one is a PVC, that is called trigeminy. Okay, so every third beat is a PVC, and at least these are monofocal. They look like they're starting from the same spot. Okay, this right here, this is not good. These look like little ghosts. Ghosts are bad. Okay. Students, what's happening here is we can't, there is no PR interval because we don't have a P wave. Okay. We definitely do not have a P wave for every QRS. As far as the rate goes, we've got, so our rate's 130. Is it regular? Yes. Our QRS is ridiculously wide, at 0.36, right? One, two. Yeah, I'd say that's probably about that. And the QT interval, we can't do that. Students, what this basically is every single heartbeat is a PVC. Even worse, it's not coming from the AV node, it's coming from an irritable part below the AV node. So every single heartbeat is a PVC. We know it's tachycardic because our heart rate's in the 130s. This is called vtach or ventricle tachycardia. Okay. If your patient has this rhythm, you got to call a rapid response. Your patient, if they're awake and talking to you now, they're not going to be awake and talking to you long. This is not a stable rhythm because your patient will likely code if you don't intervene and get some help. All right. Okay. All right. So our next one, whoops, two. So we've got 80. Are we regular? No, we're all over the place. Our PR interval, let's see. Let's say that's about 3 boxes. Our QRS is 0.06. Is there one P wave to one QRS? Yes. And then our QT interval, that's not too bad, it's about 7 boxes. Okay, so this is normal sinus rhythm, which is abbreviated like that. And then this, kind of like earlier we had couplets, we have a triplet now. Now, if you think about it, students, remember me saying that sometimes PVCs perfuse and sometimes they don't. If these are not perfusing, then your patient is going from here all the way to here without a perfusing heartbeat. Here all the way to here. So your patient might be complaining of intermittent dizzy spells or palpitations. That is what your patient might be feeling. So it's good to assess your patient and interpret your rhythms. All right, let's come down here to the next one. All right, students, this is not a healthy rhythm, okay? We can't figure out the heart rate, okay? Because who knows what we're trying to, oops, let me make that skinnier. Who knows what we got? Is it regular? No. We don't even have a P wave. You can't measure this QRS. One P wave to one QRS, that's anybody's guess, and we absolutely can't measure this. Do you see how this gets wide and then it gets skinny and then it gets wide and then it gets skinny? It almost looks like party streamers. So if you have a rhythm, students, that looks like a party streamer, it is called in French torsades de pointe. Okay, it'll literally look like a party streamer. It'll get wide and then it'll get skinny and it'll get wide and get skinny. So if it looks like a party streamer, the answer is it's torsades de pointe, and you need to get this patient some magnesium because if you don't, if they're still awake, they won't be for long because they're going to crash. You have got to get them mag because that is the only thing that's going to pull them out of this. You, um, yeah, you gotta get some mag on board. That's going to be the answer to that test question. All right, going back here, this rhythm. Okay, this rhythm, it is wide, it's irregular, and this is not compatible with life. Okay, we do not know what the rate is because there's no R waves to count. We don't have a heart rate. It's definitely not regular. There's no P wave. It's an immeasurable QRS wave, like nothing. But the good thing that you have here is you do have electrical activity. This is called ventricular fibrillation. So students, just like we were talking earlier about atrial fibrillation, how it's just little sparkles, but it's not really anything of consequence and it's causing no contraction. Ventricle fibrillation is the same thing. There's little sparkles of electricity, but not enough to actually make the heart contract. Okay. And remember, we can live in AFib quite happily because that only does 15% of the overall cardiac like workloads, just 15%. The ventricles do the majority of it. So if your ventricles are just sparkling and not contracting, that is not compatible with life. Your patient with this rhythm does not have a pulse because there is no contraction going on. This is a shockable rhythm. You have to shock your patient in order to get them back. Okay. And so students, think of it this way. Have you ever walked into a classroom of kindergarteners and they're all running around wild and yelling and doing absolutely nothing purposeful or of consequence? They're just running around making noise. The teacher comes in and yells at the top of her lungs, "Shut up!" And then they'll just the kids will stand there kind of stunned and then they'll act right. That is what defibrillation is. So when your ventricles are fibrillating and not doing anything of consequence, we put the patches on, or back in the day when we used to use the paddles, we put the patches on, we crank it up to 200 joules, and we shock you. And what it does is it stuns the heart so that it'll start hopefully beating the way it's supposed to and having ventricular contractions again. Okay. All right, let's go here to our next one. All right, this is a flat line. Every TV program you've seen does it incorrectly. This has no electrical activity. When you have no electrical activity, there is nothing to shock. So that's like going into an empty kindergarten room. Like you go into the classroom and it's empty, there are no kids to yell at to get to act right because there is no activity. So you can't go into an empty room and yell and expect something to happen. You do not shock asystole. Every TV program's wrong. We don't put the patches on this person. We don't shock them with the paddles. There is no electrical activity in the heart, so there's nothing to shock. We do CPR. We do contractions and or compressions, and we'll do compressions, and we'll also give them epinephrine, but we don't shock asystole. So that is what this rhythm is. It's asystole, meaning there is no systole. Let me come over here. This is asystole. This is a flat line, and this is not shockable. So, like I said, every TV show is wrong. Come back up here. Oops. Neither one of these rhythms is compatible with life, but this has electrical activity, so we can take the defibrillator and shock them. But this one has no electrical activity, so we don't shock that. All right, stay with me. We're almost done. We're on page 7. All right, so coming back over here, we have got a rate of 1, 2, 3, 4, 5, 6, 7. So of 70. Is it regular? Yep, looks pretty regular to me. PR interval. Well, shoot, I don't have a P wave on there really to measure, so I can't really measure that. Our QRS interval, I mean, that looks pretty good. That's only 1, 2, maybe 2 boxes, 0.08. Is there a P wave to every QRS? No. And my QT interval, I can kind of measure it. About 10. Okay. This right here, this skinny little thing right here, that is a pacemaker spike. This patient has a pacemaker, and they are paced with their SA node. It's an atrial pace. So we've got paced. We're going to say 100% because we have a pacemaker spike before every heartbeat. So we are 100% paced, and it is with what we call good capture. So every time the pacemaker fired, the heartbeat responded. So it captured that electrical impulse. So we've got 100% paced with good capture. Coming down here to our next one. I do want to point out this is just a 3-second strip, so this patient's heart rate's actually 80. Okay. Oh, shoot. Is it regular? Yes. Do we have a PR interval? You can kind of measure it. That's not quite one. We'll call this one big box, so 0.2. And then our QRS, that is really wide. So that is like 0.2. Also, do we have a P wave for every QRS? Yes. And then our QT is about 0.4. This patient is 100% AV paced. So this is pacing at the ventricle. So 100% paced with good capture. All right. And then coming down here to the next one, you can see we've got 2 pacemaker spikes. So this person has a dual lead pacemaker, so it's firing at the SA node and it's firing at the AV node. And students, I pop this on here, but we really don't usually put down what the PR and the QRS is. Just know that it's 100% paced with good capture. For every pacemaker we have, pacemaker spike, we've got good capture. Here we've got dual paced. So this person here, they are dual paced at 100% with good capture. So 100% dual paced with good capture. This person's underlying rhythm, it's very reasonable to think they might have a complete heart block. So that 3rd degree heart block, they probably had that, and then they got this lovely little pacemaker. Or they might have had one of the more severe, like 2nd degree heart blocks. All right, coming down here, what I'd like to point out, so we've got somebody who's dual paced, okay? They don't have a pacemaker spike here, and then they've got pacemaker spikes here, and then, whoops, there's no QRS. So I wanted to point this one out. This is, they're dual paced, okay, because I can see my dual pacemaker spikes, so dual paced. This is what we call on demand because they don't have a pacemaker spike every time their heart contracts. So it's on demand. And here is what I want you to recognize. This is the big whoopsie. We have to make sure the provider knows. We do not have 100% capture. We need to let the doctor know that the AV, that the pacemaker is not having 100% capture. We need to let them know, and then they can work on that. And then I've got some of these things here that I want you to understand. When you have this is an upward deflection and this is a downward deflection. Okay. So here we have, oops, I need to turn this back on. So this is baseline. You know this is your Q, R, S. This T wave is up way too high. This person really needs an EKG because I want to know, is this ST segment elevation or is this just a really bad wide QRS? But this looks like ST segment elevation to me. Let's come down here to the next one. So we've got our Q, our R, and our S, T. Anytime you have ST segment elevation, you need to let the provider know this patient is probably having an MI. An MI, an acute MI, an acute blockage, so meaning that they have a acute an acute coronary event and they've got cardiac muscle that is starting to die. This is what it looks like on the EKG. You've got ST segment elevation. ST segment elevation. You need to get a stat EKG. And you need to get the doc in there. Get some phone some friends. This one, so here's your P wave, and when you have your P wave come back down to baseline and then immediately shoot up, this is called a delta wave. This person is going to have what they call a re-entry issue, so their wiring in their heart is a little bit off. Let me come back over here to our blackboard. So that instead of the cardiac conduction always going from the SA node down to the AV node and then around, sometimes it has like an extra part that comes back up here and loops up to the AV node or SA node. Those patients a lot of times have to be on some medication to keep their heart rate under control. This is called ST segment depression. Here, I want you to be able to recognize that sometimes our patients who are having heart attacks will start to have ST segment depression, and then it'll flip up to ST segment elevation, or this could be from an old MI. Clear this out of the way. All right, let's come back over here. On this other sheet, students, I do have like how to read this. And then I want to come down here. Sometimes your patients will have what we call a bundle branch block. It'll look like their QRS is extra wide, and it's actually because they have two R waves. A bundle branch block is a little bit different than the heart block. So the heart blocks, our problem is in the AV node. If you have a bundle branch block, that means one of these three bundle branches has got just a little blip in it, and it takes it a little bit longer for the conduction to go through just on the bundle branch. Okay, so in a perfect world, when your AV node fires, both the conduction on the right and the left bundle branches, they're supposed to come down in cadence. If you have a bundle branch block on one of them, they'll start to go down, and then one takes a little bit longer and then it comes up. And that makes your QRS look wider, which is why we look at the QRS when we're interpreting our strips. And if the QRS is like too wide than what it's supposed to be, we're going to look back on our EKG and see if they have a bundle branch block. If it's a bundle branch block that they've had for a long time, and the provider knows about it, that's fine. If your patient has a new left bundle branch block, that could be the sign of an MI. You need to let somebody know. Go, phone a friend and get some help, and you need to let the doctor know. Sometimes your patients who have a right bundle branch block are a little more sensitive to fluid overload, so you have to be careful. Be careful with that. Um, there is a whole lot when it comes to reading telestrips. This video is about an hour and a half long. I know I've thrown a lot of information at you. There's a lot more to learn, but you can watch this video again and again and again to just get the basics. And you've got your worksheets to go through. As far as EKGs, you might hear about EKGs and ECGs. I say get a book that makes it very simple. The difference between the telemonitoring or telemetry and an EKG is the telemetry is just looking at like one or two views of the heart continuously, whereas an EKG is taking a picture of the heart from 12 different focal points. For example, if I was to take, we'll say my stapler, okay, and I look at it this way. If there's damage on the other side of it, you can't see that. With an EKG, we can see if the patient has like a previous heart attack or is having a current heart attack, and we want to pinpoint where that is on the heart. So an EKG, we put little monitor wires all over, and then we take a one-time look from 12 different views, okay? Because from each direction, it's going to look different. With our telemonitor, come back up here. With our telemetry monitor, look at this. Lead 1 Lead 1 on the tele um, reads from right to left. Lead 2 goes from the right upper right shoulder down. That usually covers the best real estate. And so a lot of times at the hospital when we're reading telemetry strips, we'll have it set to lead 2 to look from here to here. And then lead 3 is from the left side down. It's also handy too if patients are active in their room and they've popped off one of the wires, at least we can see from a couple other views. So lead 1, lead 2, and lead 3. And then EKGs, there are 12 different views that we're doing. That's the difference. And learning how to read EKGs is a different day. So, all right, I will get this sent out to you guys. And if you have any questions, please let me know.